Thank you, Chair. It's a hard act to follow after Dr. Arpana. I thank my alma mater for inviting me. So, kidney supportive therapy. So we'll get into the action now. We have seen how to diagnose. Let's get into the action now. So I'll be more of practical aspects. There'll not be much of theory. No studies, not many studies would be quoted. It would be more of practical day-to-day. When do you plan to start the renal replacement therapy in the kids? So the next 15 minutes, what I do is I get a call from the ICU consultant saying that a kid is admitted and I've diagnosed that he requires a renal replacement. I've looked at all the biomarkers, I've done all the furosemide stress test, I've done the renal angina, I've done what all we have heard in the last 2 hours, and I've declared that this kid needs a renal replacement therapy. So they call us and we are called into the action. So the next 15 minutes, I'll just talk through why a separate session is required for RRT in kids. We'll also look beyond the conventional indications, what necessitates starting RRT in kids. We'll see what are the available devices and the catheters which are available in India. And overall, my experience is basically with the Baxter Prismaflex. I've not used much of Fresenius CRRT machine. So it's mostly with the Prismaflex from the Baxter we are using. So I'll share my experience with it. So with a mortality of 40 to 45% for children on RRT, should we even start it is another question what the family asks. So we'll just go through each one of these aspects and try to see how best we can improve the care of the kids. So let's start with some of the unique considerations in the kids. So you can have a kid who is who weighs 2 kg and you can have an adolescent who weighs 80 kgs. So there is a wide range both in terms of size, body surface area. So one size doesn't fit all. So you need to make sure that you adapt yourself and you have all the necessary tools, necessary devices with you, which can serve the kids. Second thing is, what is the indication in them and what is the rapidity at which you need to start the renal replacement therapy? There are certain unique considerations such as the urea cycle defect, aminoacidemia, inborn errors of metabolism, where the hyperammonia is life-threatening and you may have to initiate renal replacement therapy, and you may want to initiate a RRT which can get into rapid clearance mode rather than the slow clearance, especially with the PD. So you want to be more aggressive with it. Also, we have a very large hemato-oncology unit at our center who wants CRRT to prevent tumor lysis. I mean, anticipating tumor lysis, hyperphosphatemia. Hyperuricemia is taken care by rasburicase. By hyperphosphatemia is mostly not taken care. So they want us to start. So they even ask us to put a line much prior before giving chemotherapy, and they anticipate us to start. So these are certain other indications where we start renal replacement therapy in the kids, other than the conventional indications like fluid overload, acidosis, uremia. These are the conventional indications. These are some of the additional investigations. The other important thing is what are the availability at your center, whether you have adequate staff, you have technicians who are trained, whether there are tubings, dialyzers available to you. Most of the centers, especially tier 3 cities, are difficult to source it, and they may find it difficult to even get dialysis catheters there. So finally, it's the affordability challenge. Not everyone gets the luxury of working in SGPJ, so most of the kids have to pay for their own treatment. So the affordability, the nutritional challenges, varying thresholds for tolerance. We keep stretching. Okay, let's not, kids tolerate hyperkalemia well, so I usually don't start. I'll try to medically manage as much as 6.5, 7, even if the ECG changes are not there. So we often keep delaying dialysis in them, but we know that fluid overload, if you delay every 1% rise in fluid overload, has an increase in mortality in kids. So finally, it's the willingness to accept the challenge. Come in the middle of the night. Most often the residents may not be able to get a line. You have to be there in the thick of the action. You have to put the line, and that's where you're called for. So let's discuss the type of renal replacement therapies which are often chosen. One is the peritoneal membrane, chosen in the kids, especially if they are in the infants less than 10 kg, or the vascular access based. Either it is the CRRT or the prolonged intermittent renal replacement therapy, that is the PIRRT, that's the SLED. So the goals of the therapy is what is important. Why are you doing it? For example, hyperammonia, you can't rely on PD. So the goal of the therapy, the patient characteristics, what is the weight and the body surface of the kid? And second, and the third is the center experience. What are they good at? So all these things define what is the type of RRT I'm going to choose in my kit. So the prospective pediatric CRRT registry from US spoke that kids who are started on CRRT less than 10 kg had odds of survival of 43% compared to them starting with more than 10 kg. So that 10 kg was the benchmark at that time, but things have improved after that. So the most important category is the weight. So let's divide it into three: less than 2.5, 2.5 to 10 kg, and more than 10 kg. So this is the criteria what usually Western world follows. So I mean, anyone who is less than 2.5 is usually goes for the PD. 2.5 to 10 goes for the newer machines they have at their disposal, and more than 10 kg is what the conventional. They can even go for the intermittent dialysis. So at my practice, I usually divide them into less than 8 kgs, 8 to 20 kgs, and more than 20 kgs. This is what I follow. So what, as majority of the physicians here are adult nephrologists, and we have been practicing adapted CRRT till now. What's an adapted CRRT? We have an adult machine, we are trying to fit the kids into that. So that is adapted CRRT, what we have been doing. So some of the challenges with an adapted CRRT is you don't have the pediatric dialyzers, you don't have the pediatric tubing. So what we try to do is we try to prime the circuit. There's a lot of ultrafiltrate, which is not controllable. The vascular catheters cannot support the blood flow required for this adapted CRRT. The tubings are bigger, dialyzers are bigger, your blood flow is not generated by the vascular access. And the hypothermia is more common in adapted CRRT machines, the adult machines which are used for pediatric RRT. So these are some of the complications of using adapted CRRT, but the advantage is our technicians are more familiar with it. There is a high clearance rate which is achieved, and most of us are comfortable because we have used this for years together. So the experience is what we have in terms of adapted CRRT, but there are many challenges with it. What the Western country has, what people in US or UK do have is the carpidum, which was invented by Ronco in 2012. In 2013, Aqueduct system came, and in 2014, the Newcastle system came. So all these could be used in kids below 10 kgs. So this is the carpidum, this is the Aqueducts, and this is the Newcastle infant dialysis system. So this is just what I'll just try to highlight, that this is what is available in India, and this is what I am using at my center. This is all probably, I mean, if someone goes to train in either US or UK, you get to use these systems. So what I use is the HF20. This is from the Baxter. So if you could see, the priming volume is 60 ml, and the dialyzer surface area is 0.2 meters squared. And we can do, the ultrafiltration error is less than 1%, and you can do any of these things. So the advantages of having these system, that is the pediatric specific system, is you can have a variety of blood flow rates, you have warming systems in them, and you can achieve accurate ultrafiltration controllers with them. We know the traditional challenges of peritoneal dialysis: slow clearance rate, can't use it, especially if there is an abdominal surgery. Ultrafiltration is unpredictable, clearance is unpredictable, but it is advantageous, especially in kids and resource limited settings. PD works well. So with this, in case of ultrafiltration, the newer modification is the continuous flow peritoneal dialysis. I wouldn't talk too much into this because we are not practicing at our center. So then if someone wants to follow peritoneal dialysis in AKI, the ISPD came out with the guidelines in 2020. I'm just going to highlight the salient features, which is practically important. If you're placing a rigid catheter, make sure you take it out by the 3rd day. Don't keep it for more than 3 days. If you're using improvised PD catheter, that is not centers who cannot have access to infant PD catheters, we use improvised catheters. At my center, I use intercostal drainage catheters because it comes with a trocar. So I use an ICD, and it is quite easy. 7 French ICD works well. So you can use improvised PD catheters. Recommended to use prophylactic antibiotics prior to insertion, and make sure that you use a closed delivery system and you don't have an open system. This is what the closed delivery system with a Y-shaped system. Currently, even the Y system is also being scarce, and we are not able to source Y system. So we have to use a tri-way, and that becomes an open system. So the source of infection is more common with an open system. Let's go about a case for I'm going to go through 2 cases, which is slightly different from each of them. I'll try to explain what we did different. So this is what the hemato-oncology people forced me to do. This is a three-year-old child who had a B-cell lymphoblastic lymphoma with CNS and bilateral renal involvement. Child had already stage 1 AKI. The pediatric hemato-oncology team suspected they would expect a TLS. They wanted me to put a catheter and keep the child ready as soon as they start the chemotherapy. So he was put on dexamethasone, vincristine, rasbericase was given, and cyclophosphamide was started. So phosphate started to go up, and the team of hemato-oncology in our institute is from Tata, and their experience says that phosphate is bad. So they don't wait for it to cross more than 10. So as soon as they start 10, they push us to start CRRT. And we started CVVHD in the child. And you can see how beautifully the phosphate started to get control with just about 2 days, less than 2 days of therapy. And the child was hemodynamically stable. What you could see is I have not used any PRBC priming in this child. And the dialyzer I used in this child was M60 dialyzer. This is again from the Baxter. This is the PrismaFlex machine. This is an M60 dialyzer. And I'll go to the next case. This is our machine and this is what we are using. I'll just go to the next case, which is about a 1-year-old child with an acute kidney injury, weight about 9.5 kg. That kid was 12 kgs. This is 9.5 kg. I had an 8 French left IJV in situ, but we used priming with this. So the difference between this is the dialyzer is HF20. What I spoke about HF20 in my previous talk, if I go through it, and this is M60. So what is the difference between a HF20 and an M60? I'll just go through it. As I said, I'm using mainly the Baxter system. So M60 basically is approved for more than 11 kgs. It is made up of acrylyl nitrite membrane. This is what the membrane is. The problem with this is if the blood is acidotic, or if you are priming with the PRBC, which is again acidotic blood, the bradykinin gets released, and that can cause severe hypotension. So we use this membrane only when, like for example, I showed the hemato-oncology child in which the ABG was great. I just used it to reduce the phosphate. So while I use my HF20 membrane when the child is acidotic or when I have to prime with the PRBC for the child. In the previous kid, I didn't have to prime the blood, or there was no acidosis in the kid. I used AN69, which is the M60 set. It is much cheaper. HF20 is much expensive. That's the difference. And also the body surface area, if you see, it is 0.6 meters squared in M60 set, and in HF20 it is 0.2 meters squared. So I use it in 8 kilo kids also. Coming to the vascular access, this is the standard table. What is available in India is usually, previously we used to have the 7 French. Currently we are difficult to source 7 French. Currently we have the 8, 8.5 French, 10 French. This is what we are using. Duraflow Meditech comes with 6.5 French. Again, the flow issues are a problem when you use a smaller catheters, especially with the bigger tubings. So let's move on to the prescription. What's the standard prescription, what we use for that? So given the discrepancy between the prescribed and the delivered dose, we should always go for the prescribed dose, which is much higher than the delivered dose. I usually go for about 10 to 15 higher. So the prescribed dose is usually about 30 to 35 ml per kg per hour. When I say that prescribed dose, it is the effluent dose. That is the effluent which is coming out of the at the end of the dialysis. So usually the delivered dose will be around 20 to 25 ml per kg per hour. And in case if you are doing a high volume CRRT, it goes up to 80 ml per kg per hour. This is especially required in cases of hyperammonia. Anticoagulation, this is what we try to maintain. One thing is heparin is the cheapest. Regional citrate anticoagulation is the most expensive. RCA is best with the Fresenius machine because they have 7 pumps, and one of the pumps is coordinated with the blood flow. So as the blood flow increases, even the regional citrate anticoagulation dose also increases. It's very well primed for Fresenius machine, not for the PrismaFlex. So we do not use much of RCA at our center. Whenever we require, we use prostacyclin. Prostacyclin is a very good anticoagulant, especially in some patients who have coagulopathy, inherent coagulopathy. We can use prostacyclins. It inhibits by platelet aggregating. We have very good experience in pediatric patients with prostacyclin, especially in pulmonary arterial hypertension patients, and that's what we use. Rest of the things are more academic because they are used in adult patients. So the typical prescription, we have a blood flow rate of 4 to 6 ml per kg per minute. We keep a venous return pressure of less than 200. The rate of replacement fluid is about 2 to 3 liters. This is for not the high dose one. Alternatively, we can just go for 35 to 40 mils. The net ultrafiltration is about 1 to 2. I usually split pre-pump and post-pump if I am using a CVV HDF, half pre-pump, half post-pump. And do not have more than 10% of the extracorporeal blood volume based on the intravascular blood volume. Outcomes, last two slides. Outcomes, mortality is up to 80% in post-hematological malignancy if you are using it. Liver disease, 60% mortality. Best outcomes are seen with renal failure patients. In renal failure patients, the CRRT has very good outcomes and mortality is less than 1/3. So the takeaway points are wait, don't initiate because we have seen the high mortality rates. PD for infants less than 8. In future, if infant CRRT machine devices are available, we can have precise ultrafiltration with it. Prepare better, insert a PD catheter at the time of cardiac surgery. This is what we do, we prepare, or we inserted a vascular access before we started chemotherapy. This is how we prepare better. CRRT is preferred method in critically ill and hemodynamically unstable patients in PICU because it helps for gentle fluid removals and prevent episodes of secondary AKI, ensure we have an adequate follow-up of these patients who survive. In CRRT machines using AN69 membrane, make sure that we do not prime the circuit. We can use the blood in the periphery line but not prime the circuit. Yeah, thank you.